everyone. I see that still people are joining to our webinar. In the meanwhile, I will introduce our first presenter, Dr. Pablo Vial. Dr. Vial is the director of the the director of the program of Hantavirus and Zoonosis of the Institute of Science and Innovation in Medicine of Facultad de Medicina, Clínica Alemana, Universidad, Desarrollo. And he's also one of the principal investigators of SENTINET, a research center which Eduardo already introduced and which will be looking at pandemic preparedness in our country. Dr. Vial is one of the Chile's leading experts in infectious disease and emerging viral pathogens. He's a pediatric infectious disease physician at Clínica Alemana de Santiago and professor at Universidad Desarrollo. Over the past decades, he has played a central role in the clinical and scientific understanding of emerging infectious disease in Latin America, but particularly in hantavirus. His work has contributed substantially to improving the recognition, the management, and epidemiologic understanding of the disease. He has been actively involved in international collaborative research on viral infections, and particularly in hantavirus. And today he will share with us his experience and insights on hantavirus disease, drawing from decades of clinical care, research, and also public health engagement. So thank you, Dr. Vial, and please you can start your presentation.
Okay, thanks for the invitation. I'm really glad to participate on this important initiative. I will try to give a very tight summary of what we have learned the last 30 years. First, I have no conflict of interest. We have had support of many agencies. And I have a very special acknowledgement. I really appreciate all the collaboration that we have from our patients. As a brief overview of the historical development, this disease is the hantavirus infection is known from in the initial early of last century. In 1954, it captured the attention of the Western world because 3,500 people, UN and US troops were affected. So a lot of attention was put in Korea, on the War of Korea, and ended up in 1976 identifying the virus that was called Hantan, because the first cases were identified in the area of Hantan River, in the border of Korea, North Korea and South Korea. Later on in 1993, as you see in this paper, there was discovered a mystery flu that killed 6 in a tribal area. Actually, there was also hantavirus, but it presented in a different way with basically a cardiopulmonary syndrome versus the kidney involvement that was present in the Asia and European cases before. In 1997, there was an outbreak in El Bolsón, Argentina, actually in 1995, 96, in El Bolsón, Argentina, and then in Chile. And since then, many viruses have been identified in different regions of America and also of Europe and Asia. The number of annual cases that we have had has been decreasing over the last few years. As you see, the American continent has approximately 300 cases a year, while in Asia and Europe there are 25,000 cases. The diseases that present in both areas, Eurasia and Americas, is quite different, although there's some superimposed symptoms and systems that are affected. In the Americas, is a zoonosis transmitted by mice, acquired by humans, and it affects mainly the endothelial cells of mostly all the organs of the system. But in America, the most prominent affected are the lungs and the heart. While in Europe and Asia, the virus, hantavirus, is acquired by almost the same transmission modes. It also affects the endothelial cells, but it's the focus of the damage is most prominent in the kidneys. So this one is called hemorrhagic fever with renal syndrome, and in the Americas is called hantavirus cardiopulmonary syndrome. Where is the virus in nature? It lives in the cells and bloods of wild rodents, and more recently also it has been found in bats, moles, shrews, reptiles, and fish, although they have not been related to human infections. In Chile, and in the south of Argentina, the natural reservoir is the long-tailed mouse, and the infected mouse lives with the virus but does not become ill. There's no biological consequences of the infection, and only 1 to 6% of the long-tailed rodents carry the hantavirus. There are some situations in which this prevalence increases, especially when the dynamics of the populations is too high. But usually it is uncommon for the mice to be infected. I'm going to say something about the virus. Basically, this is a RNA virus. It's a 3-segmented virus with the 3 segments called S, L, and M for small, large, and medium. And this virus is an envelope one, and is not very resistant to environment conditions. So it's sensitive in terms of their infectiousness to light, to drying, detergents, and chlorine. So this is the base of what we recommend for prevention of the virus. Basically, to wet surfaces with water and detergents or water and chlorine, ventilating places, and make it open the windows and make it more light. In open spaces, the virus can survive 1 to 2 hours. In closed spaces, it can survive for more than 24 hours, especially if it is dark and not ventilated. And in burrows or nests of the mice, the virus survives for up to weeks, for 2 weeks. Hantavirus is endemic in Chile. Here you have what has the number of cases reported in the last 30 years. It's about 30 to 60 cases per year. The number of cases by region is are in the blue bars, and in the green line there's a variation of the case fatality rate of the virus. It initially was about 50 to 60%, and it has become lower, around 20 to 30%. This year especially has been a year with many cases, and also with a high case fatality rate, 2026. It affects mostly men, young men. Mean age is 34 years. We have the special thing that in our cases, in our epidemiological situation, about 15% of the cases affect children. and the mean case fatality rate all these years has been 35%. How do people get infected? This occurs primarily in enclosed, poorly ventilated, and poor light spaces with recent presence of mice. Is acquired by inhalating small droplets or dust contaminated with saliva, urine, or droppings from infected mice. We have had 2 cases, very infrequent, among about 400 cases that we have seen in these 30 years. So 1,400 cases. 2 cases of rodent bites that has transmitted the disease, and also some particular thing that we see here in Chile is that sometimes the disease behaves in clusters. So we have many clusters of cases, and some of them are because transmission of person-to-person transmission. The perhaps the most important situation or cluster that we have had occurs in Argentina, Epidemiology, from November 2018 to February 2019, where, as you see in this report in the New England Journal of Medicine, there was super spreaders, and 34 cases were confirmed, and 11 of them died. There's a very nice diagram in that paper in which they describe how this disease was transmitted, and there were at least 3 or 4 rounds of infection, 3 or 4 incubation periods in which new cases appeared from an index case that was celebrating a birthday party. Regarding how person-to-person transmission can occur, Marcela Ferrez has done very nice work trying to identify what kind of fluids or what kind of secretions may be involved in the transmission. And in this prospective study of 131 patients with confirmed hantavirus infections, the samples were taken for 3 weeks, once a week for 3 weeks since admission, in different bodily compartments. And what they found was that basically the most important source of virus in humans are blood, and especially the Buffy code. 100% of the patients have the virus in Buffy code, a little bit less in plasma, and as you see in the third in the kind of pink blue line that I'm putting my arrow in is gingival crevicular fluids. That's saliva that is very close to the gums and the teeth, in between the gums and the teeth, where usually more inflammation is. So at least 60% of the patients have the virus in gingival crevicular fluids in high loads. So that the gingival crevicular fluid may be an important source of person-to-person transmission. Regarding the clinical the clinical course of the disease, it has a prodrome of that lasts 2 to 6 days. The symptoms are like a flu-like illness. It presents with fever, headaches, myalgias. In Andes virus, abdominal symptoms are prominent. Gastrointestinal symptoms are prominent with nausea, vomiting, and abdominal pain. We have had a few patients that had gone surgery for acute abdomen because of the of these symptoms. And also is of note that when you do a complete blood count, a very simple test, platelets are very early on in the course of the disease low. So thrombocytopenia is a marker, a very early marker of of this infection. So a flu-like illness with low platelets in Chile, you have to think about hantavirus. We also see increase in the liver function tests, and also hyponatremia. But the most early laboratory component that you should look to is platelets. After these 2 to 6 days, there is a very broad worsening of the disease within hours. It changes completely. It goes to a respiratory failure, low cardiac output, and shock. And what I'm signaling here with these red lines is that some patients go with a very severe respiratory failure and shock, and also there is some patients follow a different course that has less. The respiratory failure is less severe, kind of a mild disease, and usually they don't develop shock. So there's few. There's different courses of the diseases, different clinical expressions. Of course, I think that I've signaled here is about 60 to 65% the people that goes with the most severe course. The questions that we have initially were how to predict outcome, how to predict what is going on after, what will go on after this prodrome, and also signaled here with a star what happened at this moment in which everything starts going very fast in a very severe disease. So what happens at this point? And what we have learned is that some patients, just affirming what I was saying before, some patients have a severe course in which the virus goes to reach the lungs. Then we have lymphocytes going to control the disease, but in that process, there is a plasma leak, and the patient develops severe respiratory failure. In other patients, the same phenomena occurs. Basically, the virus is in the lungs, lymphocytes move to the tissue, but the virus replication and the immune response is controlled in such a way that no plasma leak occurs, or just a little bit of a plasma leak, and infection is controlled. So from very early study, we knew that the virus follow endothelial cells. Here you see a slide from Saki in 1995, in which with immunohistochemistry, you can follow the places where the virus is, following the small vessel in the lung. And what basically we think is going on is that the endothelial cells have a functional change, not a structural change. So there's no damage to the cells. This is not a lytic virus, but a one that produce an immune response, an inflammatory response that separates basically the tight junctions of the endothelial cells and produce this plasma leak that produce the pulmonary, non-cardiogenic pulmonary edema that we see in these patients. There's also a change in the function of the heart. There is a cardiogenic shock, also because of these inflammation markers, and also a decrease in contractility caused by the virus. So most patients die during the first couple of days of the disease, and this is because this transient change that we see, this transient functional change, is quickly reversible, and so after 2 or 3 days, the function of the endothelial is restored. But some patients that develop shock will not resist the infection. So it's as you see here in this graph of the follow-up of 100 cases in one of our series, is that if you are able to support the patient for those 24, 48, or 72 hours in which this change in the endothelial cells is present, you're in the other side, and the patient is going to recuperate also in a few days. And that's basically the basis for using ECMO. Is a short ECMO in which you have to support this transient defect. Regarding prognostic markers, we have found that low platelet count is associated with progression, so it's very important to follow the number of platelets. Less than 40,000 platelets is associated with a higher probability to progress to severe disease. And also we found that when the kidneys are involved with proteinuria, is associated with mortality. Regarding the diagnosis, where most detection diagnosis is based in serology. Most used test is ELISA with the capture antigen changes with a geographical area. IgM appears late in the prodromal phase. So in some cases, if you do serology very early in the course of the prodromal phase, it may be negative. And also we are using a lot of rapid tests based on immunochromatography, and we have had some false positive tests. Some of them because of the sample being refrigerated. Perhaps a more promising diagnostic test is using RT-PCR in blood, in other biological fluids or tissue. RT-PCR detects the virus genome, and it has an early appearance even in the prodromal period, and also we have found it during the incubation period. And also we can do quantification of the viral genome. Immunohistochemical techniques are used for biopsies or autopsies, basically. The possible therapeutic interventions is that this is going to be explained during the next talk. We know of a clinical placebo-controlled trial of ribavirin. There's as an antiviral, and it didn't work. It didn't have any impact in mortality. methylprednisolone. Well, we also did a case, a placebo-controlled trial in 70 patients, 35 in each group, with and without methylprednisolone, and we didn't find any impact in case fatality rate. ECMO is, of course, has been a promising technique to support the patients during that critical period of 48 hours. And also we have used based on the success that had in the Argentinian hemorrhagic fever, in which they decrease the case fatality rate of the infection by Junin virus from 25 to 1% using neutralizing antibodies obtained from convalescent plasma. We have used that, and we know it is now a kind of an experimental therapy, and we know that it could be useful when used early during the prodromal phase. And it's not that it hasn't shown effect when the virus when the Hantavirus syndrome is in place. So our reflection is that using either neutralizing antibodies or antiviral drugs is less useful when you have a immunopathogenic mechanism in place. That moment in which the patients began deteriorating is mostly because there's a pro-inflammatory response from the patient, and viral replication has less to do with the pathogenesis at that point. There's some experimental therapy neutralizing monoclonals. They're okay in preclinical trials, although have the same limitations that they have to be used in very early in the course of the disease. It could be a resource for exposed people, for example, and also in experimental way, the antagonist of BGF, and in the cases in Europe, they have used in a couple of patients icatibant as a antagonist of bradykinin. ECMO, in our experience with veno-arterial ECMO, indicates the results indicates that 80% survival rate in patients with indicators of fatal prognosis. Just to finish, hantavirus infection, we are troubled by timely clinical suspicion. This is a disease that usually is not suspected initially, and patients go over 2 or 3 medical evaluations before the diagnosis is suspected. We need, because this disease presents in unusual places, or maybe rural places very far from complex health centers, we need point-of-care testing to detect the virus. We lack specific treatments, and just motivated by what is going on in the cruise ship and all the passengers and personnel of the cruise, we need to develop protocols for diagnosis, interventions, and isolation protocols for exposed individuals. So I would like to thank many people that have been involved in what I have just presented, from all over Chile, and really interdisciplinary, many different disciplines present here. This is my group in the Clínica Alemana and Universidad, Desarrollo. And just a final message that at least in Chile, we have to protect natural predators. It's not the case in the cruise ship, but in Chilean nature, protect cats and natural predators. Thanks a lot.
Thank you very much, Professor Vial. It was a wonderful lecture with a huge overview of the disease. I think we have one question from the audience by Dr. Vishal Gupta. In your experience, what other causes of false positive IgMs would you consider beyond the one that you mentioned?
I don't know exactly why we have false positives, but we have seen not only frozen or samples, but fresh samples that are also false positives during the acute phase, and we're not sure what is that caused by. So basically, it is a test that is not completely reliable in both the positive results or the negatives. The negatives basically because the patient may not have enough IgM at the point in which it is tested, if it is early on in the infection, and the positives. The one thing that was identified that was testing samples that were frozen, but we also get some positive tests in fresh samples. So the lesson is that you cannot trust completely. It's not a confirmation test. It's just a screening test, and always you have to confirm by sending a new sample to a reference laboratory or doing RT-PCR.
Thank you, Professor Vial. Thank you very much. Yeah. I think we will take the rest of the questions that have been placed in the chat. So after for the Q&A discussions, because they're very interesting. And in that way, we can follow with the program. I would like to introduce Dr. Paula Fernandez. Dr. Paula Fernandez is internist and intensivist from Universidad de Concepción. She's the deputy director of the ICU at Hospital Guillermo Gran Benavente. And she's an assistant professor at the Faculty of Medicine from Universidad de Concepción. Paula will show us in the next 30 minutes the critical care management of hantavirus syndrome. Paula, the microphone is yours. Thank you for being with us today.
Well, okay. Thank you, Alejandro and Eduardo, for the invitation to share our experience, our ICU perspective of the management of the most severe presentation of the hantavirus. I would like to share the presentation. I don't know if I can.
Please share. I think you can.
Dr. Vial is still sharing, maybe?
Yes.
Yeah. If Dr. Vial can stop sharing, so. There.
Okay.
Perfect. Thank you.
Okay. So I would like to say that I'm here today speaking on behalf of a Chilean group of intensivists, which bring together intensivists from different universities and hospitals across the country. And what I will do, like in this talk, is focus mainly on the practical ICU management of the cardiopulmonary syndrome in HANTA. Okay, so I would like to show you what we do in the ICU to treat those patients. So Chile is a middle and income country with a very particular geography. So over the years, that has led to develop a critical care network with different levels of complexity. So this has allowed to transfer patients to different cities who need advanced support. And that's what we do in Hantavirus. Our center in Concepcion has 56 ICU bed, and we have treated patients with hantavirus since 1997. This year was our first patient. We have treated more than 200 patients over those years.
Paula,
So
I'm sorry?
Yes?
The slides are not moving. No se mueve la tierra.
No, I'm just introducing.
Okay.
Okay, so just for give you some context, this slide shows all the patients with hantavirus cardiopulmonary syndrome who were supported with ECMO in our ICU between 2016 and 2025. We have treated 37 patients. Most of them were male. The average they have 41 years, and they came from different cities in the south of Chile. The time of connection was 122 hours of connection in ECMO, and the length of stay in the ICU was 16 days. And the most important is that the survival rate was 70%, which is very close to the outcome seen in other ICU in Chile. So like Dr. Vial explained before, and I think this is very important to understand the symptomatology of the cardiopulmonary syndrome, I would like to say that this is the central event of the pathogenesis of cardiopulmonary syndrome, is the increased vascular permeability. And it goes because the virus take contact with a beta-3 integrin, who is placed in the endothelial cells, and there's functionally changes. There's not a lytical problem in the endothelial barrier, but it's functional. And this process predominantly affects the lungs. So that's why we have because of the endothelial barrier losses its integrity, it results in an increased capillary permeability, and in the lungs it produces a profound leak syndrome with plasma extravasation and to the pulmonary interstitial alveoli, and eventually leading to severe non-cardiogenic pulmonary edema. So in addition, because of this rapid shift of fluid from the intravascular space to the third space, mainly in the lungs, the patient typically also develop hemoconcentration with elevated hematocrit levels, so who is also a diagnostic finding in this disease. But the good news is that the phenomenon is reversible, and by around the third day, we usually begin to see clearly a clinical resolution of the capillary leak. And on the other hand, the virus also interacts directly with platelets through the same beta-3 integrin, and this interaction together with the endothelial injury, it leads to a marked drop of the platelet count, so it results on a profound thrombocytopenia. Okay, that is also a key diagnostic find in this disease. So within the timeline of the disease, we are placed now after the prodrome, the hantavirus cardiopulmonary syndromes dure 5 to 7 days. Those are the most I would like to say difficult days to treat. If we can pass through those days, maybe the patient will be safe. So obviously, hantavirus cardiopulmonary syndrome is characterized mainly by respiratory and circulatory manifestation. And regarding respiratory failure, this is primarily driven by the increase in pulmonary capillary permeability, leading to not cardiogenic pulmonary edema, and patient progressively develop hypoxemia and increased work of breathing, which may be eventually progress to over respiratory failure. So this is our typical image when we admit a patient. We normally perform a chest X-ray, and we can see here the bilateral interstitial infiltrate that is very typical of the disease. And with or without associated pleural effusion, normally at the beginning we don't see much often that. And regarding the circulatory dysfunction, I think it's very important to mention that in our experience, we have identified three sequential hemodynamic components. The first is a distributed pattern, okay, probably related to the release of cytokines and other pro-inflammatory mediators. And this phase is usually relatively brief because the most important phase, I would say, is the hypovolemic component due to the profound capillary leak with rapid fluid shift from the intravascular compartment into the extravascular spaces. So I think this is a very important moment in the treatment of this disease. And then finally, this progress to a more prominent myocardial involvement, and it characterized by decreased myocardial contractility and subsequently impairment in cardiac output. And that is very clear also when we see in the clinical practice. So regarding ICU management of these two major systems, there are several key supportive strategies, especially because, as Dr. Vial said, we still do not have a specific therapy for this disease. So in our practice, management is mainly based on 4 pillars: hemodynamic monitoring, fluid and vasoactive therapy, the ventilatory support, and ECMO support when it's needed. So I will explain a little bit how we do our hemodynamic monitoring strategy in those patients. It's important to say that many patients can arrive very stable clinically. So even if it's that the case, we place an arterial line and we monitoring serial capillary refill time. This is considered essential for us. And as I said, even if it's in patients who appear to be clinically stable. And then we perform a bedside echocardiography always and as a baseline, and then a follow-up for anytime it is needed. And then if the patient start to require vasoactives, or if we see signs of impaired perfusion, so we perform continuous or at least very frequent cardiac output monitoring by Swan-Ganz catheter or other devices of continuous monitoring of cardiac output or PICO. It depends a little bit of the availability. Then about the fluid and vasoactive drugs management, I think this is a very important and also a very controversial point, because we have here a clinical challenge. We have a profound intravascular hypovolemia in one hand. The patient is severely depleted of volume. And on the other hand, we have a massive extravascular congestion in the lungs. there is a severe pulmonary edema. And so what we do with fluids? Normally, we do a volumization with crystalloids and also sometimes with albumin, but it's very individualized on the requirement of the patient, because many years ago the strategy was very restrictive, but maybe it's because historically the balance was very, very positive, over 10 liters, 20 liters. So of course, in this situation, the lungs were very suffer or of more edema. But maintain the patient with excessive restrictive resuscitation also have very severe problems, because it's impaired tissue perfusion in patient with profound hypovolemia, but also if the patient require a connection to ECMO, this extreme hypovolemia impairs the adequate function of the pump flow. So what we do is make a very individualized balance and fluids therapy to maintain adequate intravascular volume without worsening pulmonary edema. And about the vasoactive therapy, the first vasoactive drug of choice is norepinephrine. And we also use in certain cases in OTROP, also like sometimes like a bridge to ECMO connection. We do not always use a second vasoactive drug, because when we see that the circulatory function is getting worse, we think on ECMO initiation. So about the ventilatory support, there are different ventilatory scenarios in the ICU. In our experience, we have used high-flow nasal cannula, non-invasive mechanical ventilation, and invasive mechanical ventilation. Many patients can actually be managed with respiratory support alone, using following standard acute respiratory distress syndrome strategies. Even in case with very, very severe respiratory failure, if circulatory function is okay, we have managed those patients in mechanical ventilational, but conventional. So I think the respiratory failure is not the big problem. Probably the big problem is the circulatory dysfunction, and when it shows, we have to connect the patient to ECMO, and that's what we do in our ICU. So historically, management has primarily focused on ERDS. However, I think, and it's what we see every day in our ICU, circulatory dysfunction is the component that most often determine mortality. That's why the connection is on ECMO VA. So when we decide or when we have a patient and the circulatory dysfunction is progressing, we have to think about the initiation of ECMO. We have to maybe answer the question why we are going to do it and when. And when probably is a very important question to be answered. This is it's the first major report describing the use of veno-arterial ECMO in patients with hantavirus cardiopulmonary syndromes. It was published in 2011 by Crowley of the University of New Mexico in the Four Corners in the United States. And in that series, 51 patients required ECMO support, and overall survival was 66%, which was a very important finding at this time. But another very important point is that this study and the authors clearly describe the criteria used for ECMO initiation, and many of those criteria are associated with an expected mortality close to 100%. So in a way that help answer the first question, why do we use ECMO in this patient? It's, well, because without extracorporeal support, maybe patients present a degree of severity would most likely definitely not survive. So with ECMO, more than 2/3 of patients will live. And in our center, we observe this effect also locally when we have the availability of ECMO in our center and the phase pre-ECMO, and we show also a decrease of the mortality. And so I think this is very important to use this therapy support. So when to initiate ECMO, it's important. The importance of determining this timing of ECMO initiation is because the progression of cardiopulmonary syndrome to multi-organic failure is very quickly as hours. We can see a patient with a little bit of respiratory failure, with a little bit of circulatory dysfunction, and in hours it could be collapsing. But also ECMO has risk, and we have to decide very precise why the patient who are going to be initiate ECMO. In Chile, National Ministry of Health recommendation for the management of hantavirus disease was have existed since 2007. These guidelines already include criteria for ECMO initiation within the management algorithm. And importantly, those criteria will always base mainly on hemodynamic variable. And the study by Crowley also describes specific criteria for ECMO initiation, and these have probably served on the basis for mainly of the subsequent recommendation and guidelines published on this topic. In 2019, we also reviewed the condition under which our patient had been connected to ECMO, and we found that our practice was quite consistent with the criteria previously described in the literature. And overall, this finding could be summarized as follows. Before ECMO initiation, and the patient had a mean cardiac index of 195 with an average PO2-VO2 ratio of around 110. And importantly, all patients show decreased myocardial contractility on echocardiographic evaluation. We're going to see that on the next slide. So when to initiate ECMO? Maybe as based on all of this, the current recommendation for ECMO initiation are mainly based on the following criteria that you see in the slides. And I think it's also very important to emphasize that this decision should always be made as a multidisciplinary team, not only by one person who is treating the patient. And that's how we do it here in our ICU. And of course, it's also very important to emphasize that once the decision to initiate ECMO has been made, the cannulation should be performed as early as possible, because the progression of multi-organic failure can be extremely rapid. So I'm going to better illustrate everything we have discussed so far, I would like to briefly present a short clinical case that we manage in ICU, like an example. This is a 33-year-old woman, an architecture student who initially present to a primary care hospital with typical symptoms. Hantavirus infection was suspected early, and after a positive IgM test, she was transferred to our center. The patient arrived awake, calm, able to speak comfortably with the team. During the first hour after admission, she developed a little bit of tachycardia and tachypnea, but they also improved with the rest. Despite this apparently clinical stability and given the no risk of rapid deterioration in this disease, we decide to place an arterial line and a central venous catheter early after admission. This is the nursing register. And here we can see the pattern hemodynamic parameter at ICU admission. Over the following hours, we have there was a progressive deterioration of the macrocirculatory profile, like you can see here, and then we decide to initiate a continuous cardiac output monitoring. This is the first lecture of this, but then, as you can see, her cardiac performance deteriorate very rapidly over just a few hours, eventually reaching cardiac index value that strongly suggests that she will require ECMO support, 2.4 of cardiac index. And this is the bedside cardiac ultrasound assessment on the admission. This is the first echocard we do in this patient, and this is two subcostal views. On the left, we have 5 chamber views, and on the right, a short axis view, and the systolic tick function was estimate of 45%. It's in the short axis, we can see at the base that maybe there is a little bit decreased the contractility. But at 18 hours after admission, this was the image we could get on the echoscopy evaluation. And the heart looked significantly more, a little bit more tachycardic, but with a decreased systolic function. There are no contractility effectively, as you can see in this video. So here, just to, this is a photograph of the nursing chart, and just to show that the respiratory failure was progressing. She need a connection at mechanical ventilation after 12 hours of the admission, and we start monitoring of cardiac index. That was 3.1, and the next day the cardiac index was decreased until 2, and we decide a connection to ECMO VA ECMO. This was performed in our unit. In this particular case, sometimes it's made on the OR, or sometimes also the patient are referred already on ECMO support from other cities through our mobile ECMO retrieve team. Now, in this case, we do on our SU, because as you can see in the third image, the monitor already shows profound hemodynamic compromise at this moment. And in this sequence, we can see the evolution of the patient hemodynamic and macrohemodynamic profile, together with the setting of the veno-arterial ECMO and mechanical ventilation support. On day 2, the patient still required norepinephrine, and circulatory support was essentially being provided entirely by the ECMO circuit. By the day 3, we see that the first gas flow has started to decrease, probably reflecting that native pulmonary oxygenation is improved, and norepinephrine requirements were also lower. And then by the day 5, the native cardiopulmonary system was begin challenged. She's a little bit more tachycardic, but maybe it's because we are performing a trial of assessment. And that point, the patient was already completely off of norepinephrine support. And this is the evaluation on the day 5. We have a better contractility in the myocardium.
Pero quiero ganarle lo.
And with this hemodynamic monitoring, we decide to decannulate at 115 hours after ECMO initiation. And also, I think it's very important to emphasize that there are two keys in event that usually mark the beginning of recovery in these patients. And when they occur, they give us some reassurance that the clinical course is likely start to improve. The first is the recovery of the platelet count with improvement of this profound thrombocytopenia. And the second is the improvement of myocardial contractility that we saw in the echocardiac evaluation. So it's also important, I think, to mention that although ECMO support itself is usually relatively short, often around 5 to 7 days, mechanical ventilation frequently needs to be continued for several additional days. In fact, some patients may have required percutaneous tracheostomy to achieve successful ventilatory weaning. And also during ECMO support, patient may also require another form of organ support, like including continuous renal replacement therapy, as shown in this case. It's our last case. The last week, he was with us in our ICU. So about some special consideration for ECMO in patients with cardiopulmonary syndrome, like I said, VA ECMO is preferred over VV ECMO because the circulatory function is more compromised. About anticoagulation, we have to have some consideration about because of the severity of thrombocytopenia and bleeding risk. We consider thrombolastography monitoring sometimes to decide to start the anticoagulation. And ECMO support is typically of short duration. Cardiac recovery usually precedes the pulmonary recovery, and because of that, we have to be cautious in if the potential of development of Harlequin syndrome. And because of that, in selected case with severe respiratory failure, the conversion to VAV ECMO or VV ECMO may be required, and we have performed that in our ICU also. So some message maybe to take home. I think, like I said at the beginning, the central event is the increase of vascular permeability. This is very profound. This is explain the symptomatology of the patient, and also it's reversible. So we have only to wait and through these 5 or 7 days. Very important is the clinical suspicion and early transfer to an ICU with ECMO capability. Once pulmonary deterioration begins, the circulatory collapse may occur within hours. This is very, very clear. It happens in front of our eyes in the ICU. Therapy is primarily supportive. We don't have yet at our days a specific therapy. And in the most severe case, initiation of VA ECMO has been shown to improve survival in the ICU. So finally, if you are interested also in more detailed information on this topic, you can find it in this paper published in the Journal of Critical Care by Chilean Hantavirus Group, and also to say that it's very important to thank all the team. This is the team in our ICU, and we have together learned about this disease through these last 30 years. Thank you very much.
Thank you, Paula, for this such a wonderful lecture. I think it's very inspiring and very clear the way that you deliver and give care for these patients from a perspective of intensive care in Concepcion and in all the south of Chile. So now I would like to invite you, Paula, Professor Vial, and also our guest speakers. We have Nicolás Pavés from Universidad de Concepción, Rodrigo Ulloa from Hospital Higueras, Talcahuano, in the south of Chile as well, and Dr. René López from Clínica Alemana, Universidad del Desarrollo. And we have some minutes for a roundtable. We can answer the questions from the audience. And in this sense, I would like to start with you, Paula and Nico. How often do you see differential hypoxemia or Arlequin syndrome? I know you mentioned it a little bit in the slides, but is it a real problem? Is it something that's more theoretical than actual?
Yes. Hi again. No, that's okay. Hi again. Thanks for having us today. It's a pleasure to be here. If there's any clinical question, we will be happy to answer them. And the question was about differential hypoxemia. Some of you might understand it under the name of Arlequin syndrome. We see it sometimes when the lung is still falling. We use NIRS to check for this complication. And as Dr. Fernandez said, if the heart is going well, but the lung is still bad, we change to VAV ECMO or VV ECMO. Or maybe we decannulate and use front positioning. But we saw it, I would say, less than 30% of the patients, but because the lung will be better with the time. As the heart get better, the lung will be getting better. Eduardo, I also wanted to highlight some clinical aspects of the ICU management of hantavirus and also emphasize what Dr. Fernandez already told us. Regarding
go
the question, the respiratory failure, we start always with nasal cannula, and after that we use either high-flow nasal cannula or non-invasive ventilation. Use whatever you have, whatever you are used to use. Some patients will stay there, but some may need mechanical ventilation. As a message, use the same criteria for intubation you would use for any patient. It should be easy to ventilate, just as any cardiac failure. It should respond great to PEEP and protective ventilation. Pleural effusion will develop on day 1, on day 2, faster than you would expect on any other disease. And this is the key. Because of pulmonary edema and pleural effusion, you will be tempted to use furosemide early. We recommend not to use that. Wait until the hemodynamic stabilization and then aim to negative valences. This should happen on day 5 to 7, because you will see pulmonary edema and pleural effusion. You will be tempted to use any diuretics, but it can be bad for the patient. Regarding the ECMO for respiratory failure, the veno-venous mode as an entrance mode is rarely used. Actually, after around 40 patients, we have never used a VV ECMO for only respiratory failure. We only use VAV or VV as transition to the cannulation after the use of VA ECMO.
Thank you, Nicolas.
Because sometimes some people may be wondering, because sometimes we see that patients have a depressed contractility that not so low as you usually would consider for a VA ECMO. So people may wonder why not trying a VV ECMO. Do you think it really, one of the thoughts I have is that maybe one of the things we gain by putting patients on VA ECMO instead of VV ECMO is that we are bypassing the pulmonary circulation where most of the fluid leak is happening. So I don't know if you with your experience, this goes aligned. You see a decrease in the amount of fluids that patients require after connecting to it.
I think the main failure is the hemodynamic failure. And you may see chest x-rays full with water, with pleural effusions, but they will be easy to ventilate. You won't reach a PF ratio of less than 100. After we ventilate these patients, they become 150, 180. Some in the numbers you wouldn't use ECMO, VV ECMO for them, and also with a quasi-normal compliance. This isn't a fibrotic or small or a baby lung. It is really easy to ventilate. So I wouldn't use ECMO on a patient with his PA ratio is around 180 and compliance around 40 or 50. So we don't use VV ECMO as an entrance treatment, only as a step down treatment.
Right.
Thank you,
And there's
Nico.
James.
I think James has his
Yeah.
hands up. Yeah.
Please. We can't hear you, maybe.
There.
Maybe because you're not in the panel, maybe.
No, we do not hear you, James.
Maybe it's because you're not in the panel, but if you can write your question, we can put it immediately.
Yeah.
Yeah, I think that may be the reason.
Eduardo, Alejandro, we read some questions about antibiotics use.
Okay, please.
Yes, see, we do culture our patients. Some of them are already on antibiotics due to community-acquired pneumonia suspicion. So they come with, I don't know, say Aftraxone or something like that. But if antivirus is confirmed and no other infection is suspected, we discontinue antibiotics.
Okay. And do you usually get over infections like influenza? You get like I don't know, aspergillosis, whatever. Do you see like secondary infections?
If there is any secondary infections, will be to the critical care support, but not necessarily because of the antivirus infection. There is no relationship such as influenza and Staph aureus or something like that. It's mainly because of our treatment. We do cultures such as blood cultures or viral respiratory infections, but they come almost always negative.
Okay.
Other question maybe for Rodrigo, if you want. There's a question about the possibility of using plasmapheresis, or maybe as we use sometimes high volume hemofiltration with the idea of removing some immune mediators in the blood. Do you have any experience or do you have any idea about this at an early phase, maybe before starting ECMO?
Oh, yes. We have some experience with hemorrhagization using Hafron. In my opinion, there are some favorable results, but there are not studies to support this in this context. In addition, there are some case series with high volume hemofiltration that had favorable results. I think that I think only that. But in case of Arlequin, in this center in Hospital Las Higueras, on the third day, we installed an inline ultrafiltration filter. Or if the kidney failure was very severe, we installed outline CRRT. In addition of the Nicholas answer.
Okay.
And regarding invasiveness, I think there's a great question by Pervez. Are you using preventive arterial and venous lines when you think the patient? Are you like pre-cannulating or giving the sheaths preemptively before ECMO cannulation?
We do not like all the cases. Sometimes when we see that logically the logistic of the cannulation it's difficult, we cannulate us in the ICU, and then the cardiothoracic team, that is the team who cannulate, who initiate the ECMO, they continue. But it's not a rule.
No, that's standard.
Okay.
And this is, I think, a very interesting question raised by James. If the patient's already in a cardiopulmonary phase of referral from a regional hospital, would you attempt transfer to ECMO on ECMO, or you bring him on mechanical ventilation? How are you organizing transfer of patients that have severe disease?
Well, in the south of Chile, there are not so many centers with ECMOs, so it's very frequently that patients are in primary hospital with not available of ECMO, so they have to be transferred to our centers. And when we made a call with the physician who are with the patient, and we decide on depending of the compromise of the circulatory function, if the patient has to be cannulated in the primary hospital and transferred by ECMO mobile and with us.
But you will always rescue the patient. You won't leave the patient in a center without ECMO if he's already on invasive mechanical ventilation, let's say.
If we translate on mechanical ventilation?
No, I mean, you will always transfer, if they call you for a patient who is on ECMO and invasive mechanical ventilation, you will always organize a rescue with or without ECMO. You will never leave them in a center without ECMO capability.
No, never.
Because the mortality will be very high. Okay.
Yes. Even when patient is clinical stable and he's with a little bit of symptoms, we also transfer them to our ICU.
Yeah, this is important in Chile as a protocol. So the patient, even if it's very oligosymptomatic, will be transferred immediately to a hospital with ECMO capabilities.
In Chile, it's a government policy.
Mm-hmm. This is because of the experience that when we try to set up an ECMO, when the patient already deteriorating, maybe it's too late.
Yes, the collapse is very quick. So in our, the patient can be, I've seen that the patient can be talking and then in 12 hours he's cannulating.
Other questions?
Yes, there's a question I would like to ask Professor Vidal. I think he's the most, let's say, in your experience, have you identified antivirus in the LCR, in the CSF, in the cerebrospinal fluid? And if the blood is a possible, let's say, contagious source, let's say, a blood of a patient, can it be contagious if there's a little pinprick or there's like blood inadvertent puncture for the healthcare staff?
Pablo, you're silenced, I think.
I will have to say that we don't have experience in analyzing CSF specimens. Basically, it's seldomly we see symptoms that could be an encephalitis, like seizures or consciousness compromise. Usually the patients are doing kind of quite well before the cardiopulmonary phase starts. So, and also when the patients, their patients are very ill for thinking on doing an LP. So we may have missed some CNS complications, but they're very seldom. And I don't have experience on CSF specimens being analyzed.
And about blood puncture, Pablo, if someone gets inadvertently punctured?
What was that?
If there is a puncture of the personal, what's the risk by contamination with blood?
Oh, yeah, that's a very interesting. I've seen very many questions about isolation and risk of acquiring the disease. I'm going to try to be brief. We for laboratory handling of the specimens, we use BSL-2. BSL-2 facilities, but we not always know that we are dealing with hantavirus. So it's when we know that it's hantavirus or the samples are being sent for hantavirus diagnosis, we use BSL-2 with the cabinet and so on. But there's usually the samples are handled with the usual precautions. There are no laboratory workers that we have seen infected by contact with hantavirus samples. Regarding the personnel in the ICU, the CDC just came up with a very brief isolation policy, and they recommend airborne isolation. That means gown, gloves, eye protection, and N95 respirator. And that's usually what we do, especially if specific procedures are being done, like intubation or ECMO, because of possible aerosols. But anyway, we have done serological studies on personnel, both medical, nursing, nurse aid personnel that have treated patients in different ICUs, and we don't find a different seroprevalence of infection than in the general population. So it looks like, from an epidemiological point of view, that we don't have an additional risk. But anyway, said that, we have the impression that the person-to-person transmission occurs during the incubation period or the prodromal period. And so exactly when we don't know that the patient has hantavirus, it looks like transmission, when it occurs person to person, is before the immune response has already started. So the main risk is for the front workers, for the people in urgent care, or emergency care, or people in ambulatory care that get to see the patient for the first time. On accidental exposure, we have had a couple of experiences, but no transmission had occurred. But of course, it's a concern, and as I said in my talk, we have a lot of instances of exposure, like people that know that they have been exposed to mice, people that know that they have been exposed to another case of hantavirus infection, like in the cruise ship, laboratory accidents, and we have not set up a protocol for either monitoring that patient, diagnosis, early diagnosis on that patient, or what kind of intervention can we do with them in case we find them with an RT-PCR positive, for example.
Thank you, Pablo. I don't know if we have more questions. We're a bit on time. Eduardo, what do you think?
Yes, I think we're coming up to the epilogue of the webinar. I wanted to thank Professor Vial, Professor Fernandez, Professor Pavés, and Professor Ulloa for being with us, sharing their experience and sharing their knowledge around this disease, and to each and every one of you for connecting. I'm sorry if we had some issues with the technical issues with the Zoom, but we will send you the recordings once we finish processing this video. So thank you very much for being here. Thank you, Alejandro, for co-sharing this roundtable.
Yeah, I think we will have to publish it in YouTube, maybe.
Yes.
We will probably, so you can tell other colleagues who couldn't connect that we will find a way to disseminate the webinar through open ways. Thank you to everyone.
Thank
you very
you.
much.
Thank you. Bye.
Thank you. Bye.
Thank
Bye-bye.
you.
Bye-bye.
Have a nice week.
Bye-bye.
Bye.